From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good evening, folks. This is Dr. Paul. Thank you very much for tuning to our channel this evening. Today I want to talk a few minutes about Pemphigus. Pemphigus is a skin disease characterized by bulla or blisters, and it is caused by autoantibodies against desmoglein. Desmoglein is basically a protein in the desmosomes that forms the tight junctions between epithelial cells. So these are the epithelial cells, and the tight junctions formed by the desmosomes are made up of a protein called desmoglein, and autoantibodies attack desmoglein. As a result, those tight junctions become fragile and fluid starts to build up and forms blisters. So that's the pathophysiology of Pemphigus. So it's caused by autoantibodies against desmoglein. And desmoglein is a protein in the desmosomes that forms the tight junctions between epithelial cells in the skin. So remember that, and it makes things easy for you when you think about this disease, because as a result of that pathophysiology, the tight junctions become fragile and fluid starts to fill up in that space. Now, when you apply pressure, the epidermis is easily removed, and we call it Nikolsky sign. Nikolsky sign, it is characteristic of Pemphigus. It's not specific to this disease. Nikolsky sign can be seen in other diseases like toxic epidermal necrolysis and Stevens-Johnson syndrome and a few other skin diseases. But in Pemphigus vulgaris, we see this Nikolsky sign. So Pemphigus vulgaris is a mucocutaneous blistering disease that predominantly seen in patients over 40 years. Let's say PV for the sake of brevity. So PV for Pemphigus vulgaris, it involves the skin. So PVs are characterized by fragile, flaccid blisters that rupture to produce extensive denudation of mucous membranes and skin. And it typically involves the mouth, the scalp, the face, the neck, and the axilla. So remember that. It's like the scalp, the mouth, and the neck, and the axilla. And sometimes patients develop even pruritus along with the pain. And Pemphigus vulgaris, it demonstrates bulla that are easily ruptured, resulting in multiple erosions and crusts. It always invariably affects the oral mucosa. Remember that point, folks, very important. It affects the oral mucosa, and that's a very, very important point. When you do the biopsy in these lesions, you see vesicle formation secondary to loss of cohesion. Remember I told you about desmoglein protein. That protein will be absent. And when you look at the blister cavity, you will find acantholytic epidermal cells. And the lesional skin may contain focal collection of intraepidermal eosinophils within blister cavities. And if you do direct immunofluorescence microscopy on these lesions, and you will see deposits of IgG on the surface of keratinocytes. So you will see deposits of IgG on surface of keratinocytes when you do direct immunofluorescence microscopy in Pemphigus vulgaris. Pemphigus vulgaris can be life-threatening. Thank God that we got these glucocorticoids. Prior to the availability of glucocorticoids, the mortality rate used to range from 60 to 90%. Think of that, folks. Up to 90% of patients with this skin disease used to die before the advent of glucocorticoids. But because of the advent of glucocorticoids, we have reduced the mortality rate to like 5%. And patients with advanced age or immunosuppressions and with comorbid cancer then these patients have very, very high mortality rate. But for 90% of patients, if you use systemic glucocorticoids, they survive. So the mainstay of treatment is systemic glucocorticoids. That's very important. The mainstay of treatment is systemic glucocorticoids. And you start with prednisone, 1 mg per kg per day. And if new lesions continue to appear after 1 to 2 weeks of treatment, then you can increase the dose of prednisone. And also you can combine other immunosuppressive agents like azathioprine and also mycophenolate mofetil. And there is also this cyclophosphamide. And patients with very severe, I mean, if the patient becomes like treatment-resistant disease, then you need to give them your IV immunoglobulins. You can do plasmapheresis. And there is other agent called rituximab. Rituximab. Remember that name, folks. Rituximab is a helpful agent in the treatment-resistant pemphigus. Now, there is other disease called pemphigus folliculus. That is called PF. PF, pemphigus foliaceus. This is a very, very important disease in Latin America, like in central Brazil or even in North African countries like Tunisia. This is a common condition, pemphigus foliaceus. The important point here is pemphigus foliaceus and pemphigus vulgaris, they are almost similar, except in pemphigus foliaceus, the mucous membranes are almost always spared. Important point. The mucous membranes are almost always spared in pemphigus foliaceus. Now, for the pathophysiology, I mean for the PF happening in central rural Brazil and other Latin American countries or North African countries like Tunisia, insect bites could cause this problem. I mean, the research is going on. We don't know the specific cause, but insect bites have been shown as one of the reasons for causing this problem. The other important and interesting point is in these patients, they have a higher incidence of thymoma and myasthenia gravis. So more than 30 cases of thymoma and myasthenia gravis have been reported in patients with pemphigus vulgaris. And patients may develop this problem as a result of even drugs. Now, there are drugs, this is drug-induced pemphigus. The drugs like penicillamine, captopril, enalapril, antibiotics like penicillins, cephalosporins, and piroxicam. These are the most commonly associated medications that could cause drug-induced pemphigus. So you see, folks, these medications can cause. Those are the important points. And always think about this disease when you see a question with these medications as the patient taking them. So, drug-induced pemphigus vulgaris, we have seen pemphigus vulgaris, we have seen pemphigus foliaceus. Now, I want to talk a few minutes about paraneoplastic pemphigus. Okay, with that I will stop. Paraneoplastic pemphigus, the predominant neoplasms associated with paraneoplastic pemphigus are non-Hodgkin's lymphoma, chronic lymphocytic leukemia, thymoma, and spindle cell tumors, Waldenstrom's macroglobulinemia, Castleman's disease. So these people can develop pemphigus. So you see, pemphigus is an autoimmune acantholytic mucocutaneous disease, and this is happening in patients with underlying occult cancers. So that's why we're calling it paraneoplastic pemphigus. Let's call PNP for the sake of brevity. And it can cause erosive lesions which could be very painful. And basically patients develop papillosquamous lesions and eruptions, and they become blisters, and patients develop pain, and many times they develop this on palms and soles. So you see, that's an important point. Once upon a time, we used to say, when a patient has a skin disease like blisters on palms and soles, we used to say it's erythema multiforme. But recent thinking is that those cases which were once upon a time diagnosed with erythema multiforme were actually the cases of paraneoplastic pemphigus. Isn't it interesting, folks? Paraneoplastic pemphigus. So they could cause blisters on palms and soles. And when you do biopsy of these lesions, and they show a varying combination of acantholysis and keratinolytic necrosis, and even when you see the dermatitis, and you remember when I said about pemphigus, you see that in a direct immunofluorescence microscopy, you see the deposits of IgG and complement on the surface of keratinocytes. The same thing could be seen here. Deposits of IgG and complement on the surface of keratinocytes. So remember that the predominant neoplasms like non-Hodgkin's lymphoma, chronic lymphocytic leukemia, thymoma, spindle cell tumors, Waldenstrom's macroglobulinemia, Castleman's disease, these are the cancers that can cause PNP, paraneoplastic pemphigus. And when you see the blisters on the hands and feet in a patient with occult cancer, you should suspect pemphigus, paraneoplastic pemphigus. It could go in the other direction also. For example, if you saw pemphigus like blisters on the palms and soles of a patient with weight loss, think about whether the patient is developing any internal occult neoplasm. So it goes in both ways. So treatment is again the same thing. Glucocorticoids. And most patients improve on systemic glucocorticoids. And if not, as I told you, you go for other things like plasmapheresis and other agents like rituximab, IV immunoglobulins. Those are the treatments, but the main treatment is systemic glucocorticoids. So that's about pemphigus, folks. And if you have any important points, please feel free to post them on my website. I also want to tell you about my book, USMLE Smasher. USMLE Smasher, and if you are taking clinical skills, USMLE Step to Clinical Skills, please check this book. It's very useful, and so many people have been writing to me how useful this book has been in their preparation. So I request you to also take a look at it, and thank you very much. Have a nice day.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.